Good afternoon. I am Dr. Chandrasekhar. I am introducing Dr. Naveen Chandra, MD Anesthesia from Guntur Medical College, and FNP Critical Care from Apollo Hospital, Chennai, and DM Critical Care from All India Institute of Medical Sciences. He is a consultant at Behra Hospital, Visakhapatnam. I welcome Dr. Naveen. Sorry.
I start with my content. I will be defining brain death and death, going to pathophysiology, organ donor management in the legal perspective. Next, what I will not be covering is a pediatric donor management, management of a potential DCD donor, intraoperative management, and organ preservative strategies. So, coming to death, death is defined in 1981 by Uniform Determination of Death Act. They define death as either irreversible cessation of circulatory and pulmonary functions or irreversible cessation of all the functions of the whole brain, including the brainstem death. Then later in 1995, American Academy of Neurology guidelines defined brain death as loss of consciousness, brainstem reflexes, and independent capacity of ventilated rate. So in India, transplantation of Human Organs and Tissue Act regulates removal, storage, and transplantation of human organs. This act was initially started in 1994. Later, it was amended in 2011, which came into force in 2014. Brainstem death is recognized as legal death only in India, only under TOA Act 1994. So, coming to potential organ donor. Who is a potential organ donor? A potential organ donor is defined by presence of either brainstem death or a catastrophic and irreversible injury that leads to fulfilling the brainstem death criteria. The common etiologies for the brain death include spontaneous intracranial hemorrhage, head injury, cerebral anoxia, and primary cerebral tumors. So, coming to statistics, in India, this is a statistical data in 2022 put down by Noto. Totally 16,000 transplants, out of which 16% were disease donor transplants. Tamil Nadu and Telangana leads the way in number of disease donor transplants. When India is compared to the world data, India lags far behind. It's 0.52 per million population versus 49.6 million population in Spain. So next, proceeding to diagnosis of brain death. So before proceeding to brain death, there are certain prerequisites which needs to be fulfilled. Patient should not have any acid-base abnormalities, or patient should not have any visceral arrhythmias. Patient should not be under influence of any analgesics or paralytics. Then you proceed for brain death. In brain death, we need to satisfy three criteria. One is patient should be deeply comatose, patient should have absent brainstem reflexes, and apnea testing should be positive. So there are certain panel of doctors who diagnose brain death. There are usually 4 panel of doctors. So if the panel of the doctors are in doubt or in disagreement, then you can proceed for ancillary testing. Ancillary testing usually involves digital subtraction angiography, or you do a TCD, or you do an EEG to diagnose. So these are the brainstem reflexes which you need to see whether they are absent or not. And apnea testing, you subject the patient, you disconnect the ventilator, subject the patient to apnea for 8 to 10 minutes, and then look for your PCO2 levels. If the PCO2 levels are more than 60, or if the rise is more than 20 mm of mercury, then you say that the apnea testing is positive. So brain death should be certified by 4 panel of doctors, as I mentioned before. One is a doctor in charge of the patient, hospital administrator, authorized specialist, neurologist or neurosurgeon. If neurologist or neurosurgeon are not available, even the authorized anesthetist, intensivist or surgeon physician can be included. This is the one which is modified in TOR 2014 amendment. So once the panel of the doctors diagnose brain death, it should be communicated to attendants in a stepwise fashion. The one who is diagnosing brain death and the one who is communicating, it should be like temporal separation. So once after the one who is communicating, once he starts communicating about the organ donation, the treating team can join the further discussion. So this is the form 10 which needs to be filled for certification of the brain death. It needs to be signed by all the 4 doctors who have diagnosed brain death. I'll just rush through this certificate. So coming to donor management. What are the goals of the donor management? The goals are one is optimization of organ function, and to maximize donation rate and prevent graft dysfunction after the transplant. So before to understand donor management, you need to understand the pathophysiology per se. So coming to pathophysiology, after brain cell damage, there is tissue edema. That is, If you are talking about the brain, the cerebral edema, once after cerebral edema there is raised intracranial pressure. This leads to decreased cerebral perfusion pressure. And this cycle, vicious cycle, goes on and on until there is no further blood flow. After this, there is transtentorial and transforaminal herniation. This leads to brainstem ischemia later. So how does brainstem ischemia occur? Usually brainstem ischemia progresses from rostral to caudal direction. So initially there will be medullary pons compression and Cushing's response characterized by hypertension and bradycardia. Later, as the herniation progresses, there will be a catecholamine storm where your vagal stimulation ceases, leading to unopposed catecholamine storm. These two phases usually comprise autonomic storm. In this phase, the patient is subjected to arrhythmias, stress cardiomyopathies, cardiac ischemia, and pulmonary edema. As the ischemia progresses, patient there will be depletion of catecholamines and sympathetic denervation, leading to brain death. So these are the pathophysiological changes. I will just rush through. There will be cardiovascular changes where there will be low ejection fraction. There will be endocrine changes where there will be diabetes insipidus, thyroxine insufficiency, adrenal insufficiency. There will be pulmonary changes where patients usually have neurogenic or cardiogenic pulmonary edema. And there will be hematological changes where patients are susceptible to disseminated intravascular coagulation. And there will be altered thermoregulation where patients are subjected to hypothermia. So my organ donor management, I will be dealing under these subheadings. One is hemodynamic management, hormonal replacement therapy, respiratory or ventilatory care, general ICU care, and the legal perspective. Coming to hemodynamic management, so hemodynamic instability in brain dead patient can be due to multiple reasons. Either it can be a distributive shock due to catecholamine depletions or inflammatory response, or it can be hypovolemic shock due to diabetes insipidus or osmotic diuresis, or it can be due to cardiogenic shock due to stress cardiomyopathy or low thyroid hormone, which is a kind of a controversial statement. So what about the fluids post brain death? It has been shown that liberal fluid strategy has shown to increase number of transplantable kidneys, whereas restrictive donor strategy has shown to increase the number of transplantable lungs. However, what does the consensus guidelines say? So what are the appropriate goals of fluid management? What does the consensus guidelines say is that we need to have a basic hemodynamic monitoring. What we use regularly, like a pulse, BP, heart rate, urine output monitoring. You need to do a serial echocardiography to look for myocardial dysfunction, and you need to use dynamic indices rather than going for a static variables like CVP. You need to use the pulse pressure variation, stroke volume variation, and cardiac output monitors to diagnose the type of the shock, and then you take your decision whether to give fluids or use vasopressors. So these are the hemodynamic goals which are put down by the consensus guidelines. These are like 2015 to 2016, and later most of the guidelines use the same hemodynamic goals, targeting MAP of more than 60, urine output more than 1 ml per kg per hour, ejection fraction more than 45, and they still recommend CVP of 4 to 10, which we all know is like unreliable for fluid responsiveness. So addressing this issue, Marklin et al. Use this stroke volume based fluid resuscitation versus the standard care which we use. So what they did? So the population which they include were the brain dead donors and vasopressors. In the intervention group, they used stroke volume based fluid resuscitation by pulse counter analysis or esophageal Doppler. In the control group, they gave fluid by the clinical assessment by the ICU nurse or the doctor. And the outcomes which they looked at were total volume of fluid infused over 4 hours, mean time to gain of vasopressors, the percentage of vasopressors in 4 hours, and the number of organs transplanted per donor. This is an observational study, so they put down the baseline characteristics which are similar between the two groups. So when they looked at the outcome, total fluid which was given on 4 hours was much higher in the protocol group. It's around 1.9 liters, and it's a significant difference. And they were able to wean off vasopressors early in the protocol group. So this is the primary outcome. When they looked at the organs transplanted per donor, in the protocol group, though this is a non-significant increase, protocol group had a higher number of organs transplanted compared to the control group. So they even mentioned the observed to expected ratio in the protocol group. Observed to expected ratio is much higher in the protocol group compared to the control group. However, this difference is non-significant. They could not find much significant difference. But when they looked at the pancreas transplantation, it was much significant compared to the other organs transplantation. So, is there any preferred resuscitation fluid for organ preservation? The consensus guidelines recommend crystalloids as a choice of solution. However, balanced salt solutions can be given to avoid your hyperchloremic acidosis. HES should be avoided, that is hydroxyethyl starch. It has shown to cause renal epithelial cell damage and cause post-DAP dysfunction. So coming to are there any vasoactive drugs which are preferred? Traditionally, dopamine was preferred, saying that it will decrease your ischemia reperfusion injury and has immunomodulatory effects. On the other hand, norepinephrine was not used mostly because of its alpha agonistic action, causing increased extravascular lung water and cause coronary and mesenteric vasoconstriction. Vasopressin is used by some centers, saying it can counteract your diabetes insipidus post-brain death. However, there is insufficient data to prefer one over the other. Canadian guidelines recently has proposed vasopressin as their first choice. However, we need to avoid high doses of norepinephrine because it has shown to decrease post-organ transplantation. Coming to the endocrine dysfunction and HRT, most of the hormone replacement therapy has the evidence has come from the observational studies till now. So, what is the pathophysiology? Hypothalamic pituitary axis is vulnerable to ischemic injury. Most common is posterior pituitary, where the patients, 80% of the patients present with diabetes insipidus. Anterior pituitary hormones, though it's debatable, hypocortisolism and hypothyroidism has been known to occur. What does the UNOS say? That is United Nations Network of Organ Sharing. They recommend a hormonal replacement therapy combination of methylprednisolone, levothyroxine, vasopressin. Some centers use it irrespective of hemodynamic instability, whereas some centers usually start it after the patient is having some hemodynamic instability. So, coming to central diabetes insipidus, this is the diagnostic criteria where the patient will be having polyuria, normal increased serum osmolarity, inappropriately dilute urine. How do you manage central diabetes insipidus? If the patient is hypotensive with low SVR, go ahead and give vasopressin. If the patient is hypernatremic without any hypotension, you can give desmopressin. If the patient is having both hypotension and hypernatremia, you can use both concurrently. So, why we need to treat aggressively this diabetes insipidus? Because sodium levels more than 155 has shown to decrease organ transplant function post-transplant, particularly liver. So, when should thyroid replacement therapy be considered? Thyroid replacement therapy is kind of controversial. Previous observational studies have shown, some studies have shown benefit, whereas some studies have not shown any benefit with thyroid replacement therapy. What does the consensus guideline recommend? This is in 2015, where they have recommended thyroid replacement therapy in hemodynamically unstable donors and with cardiac donors with ejection fraction less than 45%. The recommended dose is T4 20 mics bolus followed by 10 mics per hour, whereas T3 is 4 mics bolus followed by 3 mics per hour. Considering this unavailability of IV T4 or T3, Noto has proposed T4 oral 300 to 400 mics every 8 hours. So, thyroid, why some studies have shown conflicting evidence is because thyroid hormone, the pathology in the brain dead donors is similar to our sick euthyroid syndrome. So, that's why T4 has not shown much benefit in some studies. So, addressing this issue, this is the RCT, the rare RCTs which we see post donor, for the organ donation of brain dead patients. This is an RCT which is published in NEJM in November 30, 2023, where they looked at intravenous levothyroxine for unstable brain dead heart donors. So, what is the patient population which they have taken? Hemodynamically unstable heart donors within 24 hours after declaration of death according to neurological criteria. In the intervention group, you can see this is much higher dose. They are given intravenous levothyroxine 30 mics per hour for a minimum of 12 hours. And in the control group, they are used saline placebo. And in the outcome group, the primary outcome they looked at was transplantation of the donor heart and the graft survival at 30 days after transplantation. So, baseline characteristics, there was not much difference because it's an RCT. Free T4 levels were below the normal range in only 38% of the donors. So, coming to the outcome, in the primary outcome, the results were, there was no significant difference between the levothyroxine and the saline group. And the results were similar in both intention to treat as well as per protocol analysis. So, in the secondary outcome, they looked at other organs transplanted and did not find any much difference between both the groups. However, they have found the adverse effects, particularly hypertension is much higher than the levothyroxine group. Maybe it might be due to the higher dose of thyroxine which they have used than the recommended one. So, when they looked at the subgroup analysis, looking at the ejection fraction less than 50 and more than 50%, even in these groups, they did not find any much difference between the two groups. So, they concluded saying there is no benefit to treatment with intravenous levothyroxine as compared to normal saline with respect to the number of hearts transplanted, hemodynamic instability or donor cardiac function. So, the question arises why did not use T3? what they mentioned is previous studies showed no clear benefit with T3, and they've actually done a pilot study before the study and did not find any difference in the formulation. So coming to steroids, the other part of the hormone replacement therapy. The main reason to use steroids is because it's a pro-inflammatory state and an adrenal insufficiency has known to occur. High-dose corticosteroids were recommended by the consensus guidelines. Ideally, it should be administered after blood has been collected for tissue typing. So, whatever the hydrocortisone treatment, this is people, because methylprednisolone is shown to cause uncontrolled sugars, people have started using hydrocortisone. So, in this prospective cluster study in 22 ICU, they used low-dose hydrocortisone, 50 mg bolus followed by 10 mg per hour. They were able to wean off vasopressors early, but did not find any difference in organs transplanted. So this Dar et al., the one who did this thyroid study, has similarly compared high dose and low dose corticosteroid regimens, did not find any organs transplanted difference, whereas sugars they were able to control much better. So Brazilian guidelines in 2020 has just 2 to 3 slides. Brazilian guidelines in 2020 has recommended, they have given a weak recommendation and low level of evidence. However, they have recommended low dose corticosteroids in donors receiving norepinephrine or dopamine to control blood pressure. So I'll just rush through, there's no update. You need to use a low tidal volume ventilation strategy targeting your lesser peak pressures and plateau pressures. And general ICU care, which is tracheal toileting and head elevation. So I just want to stress on the legal perspective. In India, death by brainstem is used only in the context of organ donation. So what if the patient has given consent, okay, it's fine, we'll go for organ donation. What if the patient has withdrawn the consent after the brain death declaration? So this is still a grey area. Whether you want to withdraw the support or whether you want to care until circulated death. So there is no proper legal guidelines whether to proceed, what to do further. So what in 2020 Karnataka and Kerala has come up with this their own advisories and SOPs. Karnataka in their advisory has actually separated brain death and organ donation, and they have actually mentioned if the patient is brain dead, you can withdraw the life support. Similarly, Kerala in their SOP has declared the same thing. This is a way forward. Most of us are confused whether to disconnect or not, whether to withdraw the life support or not. So this is the dealing with brain death from organ donation totally. So for us, what about us? So Supreme Court in the recent judgment in 2023 has actually come up with this. If the patient is not having any, there is no benefit from life-sustaining treatment, what do we do further? Brain death comes under, there is no benefit from life-sustaining treatment. So you need to have a primary medical board where you need to have a primary physician and 2 subject experts with more than 5 years experience. So they need to agree that there is no benefit from life-sustaining treatment. Then this we need to go for a secondary medical board, which we need to have a panel doctor with a district CFO and 2 subject experts more than 5 years experience who are not included in the primary medical board. So this SMB, that is secondary medical board, should concur with the primary hospital medical board. Then previously we need to have a judicial magistrate. It used to take a long time. Now you need to just notify the judicial magistrate that SMB concurs with the primary medical board, and then you can withdraw the life support. So summarizing my the presentation, you need to have proper plan and donor protocol with excellent ICU care to have a good transplant outcome. Use of hemodynamic indices have been suggested. You can decide whether to give fluids or vasopressors or inotropes. Low dose steroids have become, a weak recommendation that are given. Whereas thyroid hormone, still the evidence is still conflicting. We actually don't know whether 10 mics per hour, 30 mics per hour have only not shown any benefit. I doubt whether 10 mics per hour will show any benefit using thyroid hormone. So, thank you.